Hello, everyone, and thank you for joining our webinar today. We're very pleased to have Dr. Richard McKeon with us. Dr. McKeon received his PhD in clinical psychology from the University of Arizona and a Master's of Public Health and Health Administration from Columbia University. Currently, he is chief for the Suicide Prevention Branch in the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration. Here he oversees all branch suicide prevention activities. He is also the co-chair of the Federal Working Group on Suicide Prevention. On average, one person dies by suicide every 40 seconds somewhere in the world. Global suicide rates have increased 60% in the last 45 years. Every 15 minutes, someone in the U.S. takes his or her own life, and for every one suicide, there are 25 attempts. This public health issue affects everyone: families, healthcare providers, school personnel, faith communities, friends, government, and others. It's important that everyone know suicide's warning signs and how to help a person contemplating suicide. Dr. McKeon will discuss preventing suicide among persons with bipolar disorder and will highlight SAMHSA's resources for suicide prevention and how they can be accessed. Welcome, Dr. McKeon. Thank you for being here today.
Thank you so much. It's really a pleasure and an honor to be with you today, to be talking with you about this important issue of suicide prevention for the nation as a whole, but particular for those suffering from bipolar disorder. So I'll be presenting some information to you, and then we hope to leave plenty of time for questions that I will try my best to respond to. If you're not familiar with SAMHSA, SAMHSA is the Substance Abuse and Mental Health Services Administration. We are a part of the United States Department of Health and Human Services, and we are the component of the Department of Health and Human Services that is responsible for promoting prevention and treatment of both mental disorders as well as substance abuse disorders. I want to, in particular, express my thanks to the International Bipolar Foundation for having arranged this webinar and having reached out to us here at SAMHSA. And you also see a disclaimer in terms that you should be aware of, which to basically summarize, nothing that I say can substitute for consultation with your own physician or other qualified health provider. So in the introduction, it was referenced that suicide is a problem not only in the United States, but really around the world, which was the reason that the World Health Organization recently issued their first report on suicide called Preventing Suicide, a Global Imperative, with almost 800,000 people dying by suicide worldwide annually. One of the things that the World Health Organization report calls for is for each nation to have a national strategy for suicide prevention. And the United States does, in fact, have such a national strategy that was issued in 2012. It's called Goals and Objectives for Actions. This is a revision of the 2001 national strategy, which was the first time that the United States had a comprehensive suicide prevention strategy. Now, I wanted to make sure you're aware of the National Action Alliance for Suicide Prevention, which is a public-private partnership dedicated to reducing suicide nationally and to implementing the national strategy for suicide prevention by championing suicide prevention as a national priority, by working to catalyze efforts to implement high-priority objectives of the national strategy, and trying to cultivate the resources needed in order to sustain progress, with a goal to save 20,000 lives over the next 5 years. So when we look at suicide deaths within the United States, there are a number of patterns that we see, and this was the chart that you see in front of you was created with assistance from the National Institute for Mental Health. So you can see, for example, that about half of all suicide deaths in the United States utilize firearms. Smaller numbers, for example, use carbon monoxide poisoning. So those focus on the means for suicide, but we can also look at it based on characteristics of the individuals or on the settings that they may access. So over 8,000 military veterans die by suicide, and about 300 per year active duty military. And so both the Veterans Administration and the Department of Defense have been very active in working to prevent suicide. We know that about 500 Americans die in jail and prisons from suicide each year. But I want to particularly emphasize those who have been in contact with healthcare settings. And one of these is the issue of those who have accessed healthcare within 30 days of their death. And that number is significant. It was 17,000 back in 2012. That number has increased. And also with increasing age, we find that the numbers who have died by suicide, who have seen somebody within healthcare, increases. So older Americans are more likely to have seen a physician than younger Americans. Also, a significant number have been seen in emergency departments for a suicide attempt in the past year. At this point in time, probably well over 8,000 have been seen in emergency departments for a suicide attempt in the past year. And that's particularly important for reasons that I'll get to in a little while. Now, an important piece of our suicide prevention efforts, it has to do with what is referred to as surveillance. And you may wonder, well, that's not treatment. What is the real importance for suicide prevention? Well, it's hard to fix what you can't measure. And with perhaps a third of all suicide decedents accessing care prior to their death, it's important for healthcare systems to track suicide outcomes. But few U.S. healthcare systems actually do track suicide outcomes. One place that we're getting information around this is from the National Violent Death Reporting System. The data that you see here is based on 16 states, sorry, but the system is expanding to 38 states, all of which will have this information on in mental health treatment at the time of their death. And what you can see is about 31% are in mental health treatment at the time of their death, and it's about 69% are not in mental health treatment at the time of their death. And that's usually operationalized as within 60 days of having received their last service, which could be psychotropic medication being prescribed by a primary care physician, or it could also be seeing specialty mental health care, a psychiatrist, psychologist, counselor, and so forth. It's useful to note that there's actually it's not in this chart here, but if you divide by gender, there's really a marked divide. About a quarter of men who die by suicide have been in mental health treatment at the time of their death. So that points to the fact that there's a huge issue with getting men the care they need. And that is certainly true around bipolar disorder and for serious mental illness in general, because we know that those with serious mental illness are at very increased risk for suicide. Thankfully, most of those with serious mental illness don't die by suicide, but they are at very high rates compared to most other groups. So I said that men, the number comes to about 25%. For women, it's about 50%. So for a woman who dies by suicide, they're just about as likely to have received mental health care as to not have. So what this data indicates is that we really need two very strong components for effective suicide prevention in order to reduce suicide nationally. One piece of that is that for those who are not receiving care, we need a strong community-based effort that incorporates primary care, faith-based institutions, schools, colleges, workplaces, to work to identify those at risk and help them get into care. But it also means that we need to make the treatment for those at risk for suicide, those who do get treatment, as strong and as effective as possible, and I'll be talking more about that. Now, the other part of this slide is labeled Mental Health Research Network Report within 12 months of suicide death. So this has to do with healthcare contacts in the year before suicide death among those who are within a number of health plans that are part of the Mental Health Research Network. And for those who are part of that health plan, 83% had contact with healthcare during that 12 months. About 17% did not have contact. But it's worthwhile noting that of those who had contact with healthcare, only 45% had received a psychiatric diagnosis. Now, if you accept the generally suggested numbers in the United States, that about 90% of those who die by suicide have a diagnosable psychiatric disorder, then what this suggests is that there may be many people who are being seen in healthcare for whom this underlying psychiatric diagnosis is being missed. Now, of course, it's also possible that it emerged after the healthcare contact, but it at least raises significant concerns that there may be many with depression, bipolar disorder, substance abuse, etc., who are being missed in our healthcare contacts. Now, let me say a little bit about the issue of affective disorders and suicide risk. Now, this is affective disorders generally, not bipolar disorders specifically. And work has been done looking at the prevalence of death by suicide. And what you find is that there are gradations based on the intensity of treatment. So the lifetime prevalence of suicide, of death by suicide, for those with affective disorders who were ever hospitalized for suicidality is about 8.6%. For those who have ever been psychiatrically hospitalized, but not necessarily for suicidality, the number is 4%. When you look at groups that have had a mix of inpatient and outpatient treatment, it's about 2%. While when you look at non-affectively ill persons, it drops to less than 0.5%. So this research comes from Bostwick and Pankratz, who worked to try to get an accurate sense of the likelihood of death by suicide of those with affective disorders. Prior to this, the estimated numbers were actually higher, at times as high as 15%. Part of that was because it was looking at hospitalized samples, for example, as opposed to all those in the community. And that was one reason for higher estimates. So these are the best current estimates in terms of the likelihood of death by suicide. And as you can see, for those ever hospitalized for suicidality, significantly higher than for the population generally. Now, looking specifically at bipolar disorder and suicide, the estimates are that between 3.4 and 14% of all suicide deaths internationally are by someone with bipolar disorder. So the different studies show a different range, but those numbers, become significant. So if you think of the fact that 800,000 people annually die by suicide, and if we were to use 10% as a number, that would mean that worldwide, about 80,000 people with bipolar disorder die by suicide. Further, if we look not only at deaths by suicide, but around suicidality, suicide attempts, suicidal ideation, what we find is that the estimates are, and varies from study to study, but about a quarter of those with bipolar disorder attempt suicide at some point during their course of illness. Okay. So again, that's a pretty significant number as a proportion of those with bipolar disorder. Now, that means that 3/4 don't attempt suicide, but it's, again, a very significant number. And the ratio of non-fatal attempts to fatal attempts is 13-1. So that means that for every one fatal suicide attempt, there are 13 non-fatal attempts. Now, that ratio is actually less than the ratio in general. What is that when somebody has bipolar disorder and they make a suicide attempt, it is more likely to be lethal, although thankfully most of those with bipolar disorder who will make a non-fatal attempt won't die, from it. But anytime there's a suicide attempt, certainly for anybody with bipolar disorder, but really for anyone in the United States at all, a suicide attempt has to be recognized as a serious sign of distress and risk that calls for an intensive response. And that intensive response has to be aware of the fact that, unfortunately, we don't have a single intervention, a single standalone intervention that by itself can eliminate all suicide risk. So it would be wonderful, for example, if we could say that if you hospitalize somebody with bipolar illness who made a suicide attempt, that when they left the hospital, their risk of suicide was gone. That we know that that is not the case, because we know that risk continues after discharge from inpatient units as well as from emergency departments, and we'll get back to that. In one study of United States veterans, 9% of those who died by suicide had bipolar disorder. Now, some excellent work has been done by the International Society for Bipolar Disorder, who set up a task force on suicide in bipolar disorder. And I'm going to go over with you some of the findings of this task force. This work has been published, and I would certainly call your attention to it. So one major point that they've made is that many bipolar disorder guidelines do not address suicide comprehensively. And this gets to an important issue in mental health care generally. At times, there's been a tendency to hope that by treating the underlying condition, whether it's major depression, bipolar disorder, schizophrenia, etc., by treating the underlying condition, that's all we need to do, and we can eliminate risk for suicide. The evidence has been more and more that that is not sufficient. And really what is required are efforts focused specifically on suicide, or as the International Society states it, to address suicide comprehensively, in addition to treating the underlying disorder. The Veterans Administration has been a real leader in suicide prevention efforts, frames it in exactly this way, and this was also incorporated into National Strategy for Suicide Prevention, that you need to treat the underlying disorder, such as bipolar disorder, and you also need to directly focus on suicide risk. A second point that the International Society Task Force made was of the high risk post-hospitalization. And that means that we must get better in the kinds of services and help we provide to people when they leave the door of an inpatient unit, or I would add, an emergency department. Because too often we lose people during the period immediately after discharge. Research in bipolar disorder has also shown that the duration of untreated bipolar disorder is associated with increased suicide attempts. So this speaks to the importance of early identification and diagnosis. Okay. An additional example that the task force has made was that comprehensive suicide risk assessment is needed, not just a focus on what's referred to typically in medical charts as SI or suicidal ideation, right? Because the presence or absence of suicidal ideation at a given moment in time is not necessarily predictive of whether someone is at risk for suicide even in the near term. There are some studies that have shown that many people who died by suicide in their last clinical encounter denied suicidal ideation. It is also the case that, that the context may influence what someone says. So if somebody's on an inpatient unit and they're about to be discharged and they're asked if they're having thoughts about suicide and the person wants to be discharged and they don't want to be kept, they have an incentive to not acknowledge the suicidal ideation. So a comprehensive suicide risk assessment is needed because there are many other risk factors in addition to whether somebody has suicidal ideation. Another good example of why you can't just rely on suicidal ideation, we know that many people with bipolar disorder, for example, may also have some issues with drugs or alcohol. Many times what happens is somebody may be admitted to an emergency room, intoxicated and suicidal. Often what happens, they may be held overnight until they're sober and then reassessed. Oftentimes such an individual may, in the morning, deny being suicidal. But the absence of suicidal when sober may be a poor predictor of whether someone may be suicidal when intoxicated. So that's part of the importance of this recommendation from the International Society. Now, I want to tell you some things about some of the work and initiatives that are currently being supported by SAMHSA in the area of suicide prevention. And the International Task Force's emphasis on the need for a comprehensive approach is exactly what the Zero Suicide movement is about. Now, when people hear the term zero suicide, they sometimes feel that that the challenge of preventing suicide is being minimized. But it's precisely because suicide prevention is as challenging as it is that nothing less than a comprehensive approach whose aim is to eliminate suicide among those receiving health care should be the goal. It's an aspirational goal. We may never get all the way there, but it's what we need to be aiming for. I have worked as a clinician and as an administrator in psychiatric emergency rooms, inpatient services, and outpatient services. I've lost patients to suicide. So I would never minimize the challenge of suicide prevention. But the Zero Suicide movement is a call for mental health systems and healthcare systems more generally to use everything we now know about suicide prevention to make the best possible efforts that we can in order to prevent suicide among those who are in our care. And many are not in our care, and we want to get them into care. But once they're under our care, we need to do the best job possible. We owe it to those that we've lost and to their families to do nothing less. So what is zero suicide? Zero suicide aims to make suicide prevention a core responsibility of healthcare. This is goal 8 of the National Strategy for Suicide Prevention. It works to apply new knowledge and proven tools to suicide care. It supports efforts to humanize crisis and acute care. And most importantly, it's a systematic approach in health systems. It's not the heroic efforts of crisis staff and individual clinicians. For too long, we have left it to individual clinicians to try to do the thing in suicide prevention that is the hardest, and that is to be sitting with someone and not only to assess risk, but to somehow predict whether this person is going to die by suicide. And that is very challenging. What's more, we've expected clinicians and clinical staff to do this on their own. What's required instead is a systematic approach within the healthcare systems that provides to clinicians and staff the support that they need in order to do effective suicide prevention. These notions I mentioned are included in the National Strategy for Suicide Prevention. They're also embedded in the Joint Commission Sentinel Event Alert that was issued just about 3 or 4 months ago that we think will have a very significant impact on healthcare systems and encouraging them to adopt these same core components of zero suicide that I'll be going over with you again in just a moment. And as I'd said earlier, part of this is that many people who die by suicide are already receiving care. So just encouraging people to get care, while important, is not going to be enough. So let me go over with you the elements of the Zero Suicide Initiative in a healthcare organization. And I should say to you, this is an effort that is being supported by SAMHSA through our Suicide Prevention Resource Center, by the National Action Alliance for Suicide Prevention. There is a website, www.zerosuicide.com, with many resources, and I believe I have the slide coming up. And in fact, the President's budget for this year has included a $30 million proposal focused on adult suicide prevention that has this Zero Suicide Initiative as its core. We don't know yet whether this funding will in fact be passed by Congress. The House of Representatives Appropriation Committee did include it in their markup. The Senate did not include it in theirs. We don't know yet whether there will be an appropriations bill or a continuing resolution instead. So we don't know whether the President's proposal will ultimately be funded by the Congress. But it is important for you to be aware of the level of support for this initiative that has been focused on by the federal government. So here are some of the key notions. The idea is that every person at risk for suicide, there needs to be a pathway to care, that there needs to be a systematic effort within healthcare organizations on identifying and assessing suicide risk, which includes both screening and also a fuller assessment. And that for those who are identified as being at risk, that they are able to receive evidence-based care, including a collaborative safety plan, and a lot of work is going on regarding safety planning. Some of you may have heard in the past, one of the most frequently utilized interventions in mental health care has been what are called no suicide contracts, where somebody would be asked to kind of pledge that they won't kill themselves. There were a number of problems with this. Not only was there no evidence that it was effective, there was actually evidence that in times it was counterproductive. In addition, it's important to work with someone about what they can do, not just about what they shouldn't do. And a collaborative safety plan works to look at a number of different areas that need to be kept in mind, and how the clinician and the patient can work together to keep themselves safe. And that this would include things like restricting access to lethal means. Is there access to lethal doses of medication, to firearms or other lethal means, and some kind of plan? That, because we know that the evidence suggests that this can be life-saving, that sometimes the suicidal urges, although sometimes thought about for a long time, that they can sometimes be acted upon quickly, sometimes within minutes of renewed contemplation. And the ready access of lethal means can be the difference between life and death. And as I mentioned before, the need to treat suicidality as well as the underlying mental illness. And then the area of continuous support and continuity of care as needed. And so that then is including things like when people are leaving inpatient units, leaving emergency departments, that continuous support is absolutely essential. Many of the healthcare organizations that are now incorporating zero suicide are baking these things into the electronic health record. And some have it so that there's a hard stop that you have to be doing these things in order to continue your documentation in the electronic healthcare record, which we think will be a spur to adherence. Now, we mentioned that this has to be part of a system. And so there's a need for a leadership-driven, safety-oriented culture. And the leadership must be on board for making suicide prevention a core priority. And this aligns with other safety-oriented initiatives in healthcare. Now, an additional piece is the development of a competent, confident, and caring workforce. Most Americans probably presume that the average mental health clinician has been trained in suicide risk assessment, management, and treatment. That is, in fact, not the case. Most clinicians, or many clinicians at least, have not been trained. Several states have recently passed laws, such as Washington and Kentucky and New Hampshire, to require such treatment. Others have approached this through regulation. So the state of California, for example, for their psychologists has issued regulations requiring training in suicide risk assessment, management, and treatment. I often tell the story about, for myself, going to a American Psychological Association approved graduate training program and American Psychological Association approved internship, that I was only exposed to one single lecture around suicide. Ironically, the one lecture that I was exposed to was the one lecture I gave, because I had a graduate professor who told the class, pick a topic and present to the class, and I picked suicide. That was literally the only kind of systematic teaching that I received. Now, I did see people who were suicidal, talked with my supervisor about them. But it's not only suicide experts who are recommending that there be better training. We have now received data from close to 40,000 clinicians. And when asked if they feel like they have the training, the supervision, and the support to work with suicidal people, almost half report that they do not. So the clinicians themselves describe, in many instances, their anxiety about working with suicidal people, which is a powerful testimony to our need to provide them with more support. And this is something that the Zero Suicide Initiative does. And that this also needs to take place within an atmosphere of continuous quality improvement. These changes can't be made overnight. There's a requirement for ongoing quality initiatives within a system to identify where the gaps are and to currently be working to get better. So that commitment to patient safety and continuous quality improvement is an absolute core component of the Zero Suicide Initiative. Now, part of what started a lot of attention being given to the Zero Suicide Initiative was work that was done in the Henry Ford healthcare system in Detroit. And in that system, they launched with the goal of zero suicide, what they called their perfect depression care. And what they found was that they actually went 6 consecutive quarters at one point without a death by suicide. And overall, they reduced deaths by suicide by about 60%. And some of the early adopters of the Zero Suicide Initiative are achieving some similar results of about a 60% reduction. So zero suicide doesn't necessarily mean zero suicide now and forever, much as though we wish that could be true. In Centerstone, for example, one of the nation's largest nonprofit community mental health systems, every month that they achieve zero suicide, they celebrate that. So, and so this was part of what inspired the effort around zero suicide. Now, as I mentioned there are core components. And in general, we don't try to micromanage the care, but we try to identify the core components and identify resources that can be used. So, for example, we emphasize the fact that the workforce needs to be trained. Okay, and so on the website is a variety of different training resources that can be utilized that a system can choose. For example, one of those is Applied Suicide Intervention Skills Training, or ASSIST, which is an excellent 2-day program. Is often given to the community as well, but is also very appropriate for clinicians. The Connect Suicide Prevention Training is another example. Others include the Suicide Prevention Resources Center's training called Assessing and Managing Suicide Risk. That is a 1-day curriculum. We also have some additional resources. There's a card that's called the Safety Card, that is a card that's a pocket card that walks a clinician through doing a comprehensive suicide risk assessment. So it's something a clinician can just keep in their pocket. We have also adapted that card into an app called the Suicide Safe app, which is available for free either through Apple or Android. And that also walks clinicians through a suicide risk assessment and has additional resource information right in the app itself. Now, another resource, I mentioned that screening and assessment is an important thing. So we identify a number of different tools. PHQ-9, for example, is a depression screen that includes a suicide question that has been linked to future suicide attempts. And then for further risk identification, the Columbia Suicide Severity Rating Scale is now being used in a number of large-scale systems, and several states are using it across their mental health systems. The state of Tennessee, for example, is an example that is using this in a widespread way across their system. This is another example of the resource available at the Zero Suicide website, and this is on safety planning as an intervention for suicidal interventions. There's a lot of work going on in safety planning in the Veterans Administration as well as elsewhere. This is another resource for clinicians. This is on counseling on access to lethal means. This is a free online course that was developed through the Suicide Prevention Resource Center and provides counselors with assistance in how to talk to patients and families regarding access to lethal means. Now, again, I mentioned the importance of treating the suicide directly as well as in addition to treating underlying disorder, because both of those things are crucial. There are now multiple randomized controlled trials that are showing reductions in suicidal behavior, all focused directly on suicidality. These include dialectical behavior therapy, which focuses on those who have made multiple suicide attempts and are chronically suicidal. Cognitive behavior therapy, CAMS, which stands for the Collaborative Assessment and Management of Suicidality. Also more recently in Europe, a 4 to 6 session model has received support in a randomized control trial that is called ASIP. And cognitive behavior treatment for insomnia has been shown to be able to reduce suicidal ideation. So again, the importance of treating both the underlying behavioral health conditions. There's an extensive literature on the impact of lithium on suicide. This is important to be aware of. And the literature in this regard shows that there is an anti-suicide effect in bipolar patients compared to placebo, when lithium is compared to placebo, or when it's compared to lithium discontinuation. But RCTs have not yet confirmed that lithium is superior to other mood stabilizers. let me go to the issue of improving care transitions. We talked about the fact that when someone leaves an emergency department inpatient unit, they are a continuing risk. Unfortunately, there are lethal gaps in many of our systems. Okay, there are, as an example, my sister, after she was diagnosed with breast cancer, had a bilateral radical mastectomy, and the day after she was discharged from the hospital, there was someone in the home helping her. Rarely in mental health care is that kind of intensive follow-up available. Much more typical is that a follow-up appointment may be given, but the rates of follow-up care, unfortunately, are poor. But there is evidence that intervention during this time has been shown to save lives and reduce suicidal behavior. Major international efforts have shown reductions in suicide in Taiwan, where they focused on following up those who attempted suicide seen in emergency departments, and they were able to achieve over a 60% reduction. And even for those who refused the program, they didn't give up on, continued to try to persuade them, and even among those, there was a 22% reduction. In England, the availability of 24-hour crisis care was strongly associated with reduction in suicides, particularly when teamed with proactive outreach following discharge and make sure that the follow-up occurred within 7 days. There are 2 randomized controlled trials that have shown reductions in deaths by suicide. This one was by the World Health Organization, and it followed up people from 5 countries all outside the United States who, after a suicide attempt, were discharged from the emergency department. And this is an example of a resource on structured follow-up and monitoring for suicidal individuals. Now, we think that this area is so important that we have now made this a requirement in all of SAMHSA's grants. Our crisis center follow-up grants that work with emergency departments, in our youth suicide prevention grants from the Garrett Lee Smith grant programs that go to states across the country as well. And here's another reason that this area is so important. SAMHSA has a national survey on drug use and health that looks at adults and whether they've had suicidal ideation or plans or attempts. And in a recent study that was published in the Journal of Psychiatric Research, we found that there was significant post-non-fatal suicide attempt mortality over the next 12 months. So what we found is that, and this is adults 18 and over, that the likelihood of someone who made a suicide attempt dying by suicide in the next 12 months was 3.2%. The rate was higher among men than women. It's about 6% among men. And when you look at those who are 45 years and older with less than a high school education, it was 16%. But when you look in general at all those who made suicide attempt and see how much mental health treatment did they get, only about 40% had any outpatient mental health treatment at all. And about 15% had between 1 and 4 visits, certainly not what we would consider adequate. This is another example of some of the tools that are available. Just mention that in our youth suicide prevention efforts, these are grants that have gone to states and tribes. All 50 states don't have them at any given time, but all 50 states have gotten a grant at one time or another. So early identification of those with bipolar illness is particularly important. Here's what we found when we've evaluated these grants. We found there is a reduction in death by suicide and in non-fatal suicide attempts in counties that were implementing these activities compared to matched counties that were not. And these are the same results with non-fatal attempts. What we take this to mean is that we're having an impact, we're saving lives, we're preventing injury, but it's not getting embedded, it's not getting baked into our systems, it's not being built in the foundation of what we're doing, and that's what's required. You can't take your eye off the ball in suicide prevention. It can't be a one and done effort. It requires continuous effort and focus. The National Suicide Prevention Lifeline is supported by SAMHSA. There are over 160 local crisis centers answering calls. The Joint Commission recommends giving those with suicidal ideation the Lifeline number, 1-800-273-TALK. There's a link to the Veterans Crisis Line. Last year, we answered over 1.5 million calls for the Lifeline. Local Lifeline crisis centers are a vital partner for suicide prevention. It's very important to talk to them, to support them, and to partner with them. So with that, I am going to end, and we should have some time for questions, and I would be more than happy to answer any questions that you might have. Thank you very much.
Thank you, Dr. McKeon. We have a few questions for you. So first, you were talking about contracts where the person makes a promise not to kill themselves, and that those have not been proven to be effective and also could possibly be counterproductive. Can you explain more about how it could be counterproductive?
Yes. Now, so I would say that there are a couple of things. So it is certainly reasonable to ask somebody if they intend to kill themselves. Because if somebody tells us that they intend to kill themselves, you know, that's a very strong factor that we need to take into account. Often if somebody is that clear that they will be hospitalized. The issue is when we promise them not to, that they may not be able to keep to that promise. And there are times where it may actually have a negative effect. First of all, it may give a false sense of security to the clinician. That's one issue. The other issue is that depending on the context, it may be experienced by the patient as being about the clinician or the system or the hospital protecting their own liability rather than concern about them. And that is what several studies have shown when people have been asked to provide their responses to no suicide contracts. So again, the key is to move from asking a person to promise not to kill themselves to a broader approach that tries to focus on helping them have alternatives when they're feeling suicidal. Thankfully, most people have suicidal thoughts don't act on them. So the fact that somebody's having a suicidal thought doesn't mean that they're acting on them, but we need to work with them to make sure that they're keeping themselves safe and that we're helping to give them tools to keep themselves safe and that they were monitoring them closely during this period of time.
Thank you. The next question, you mentioned the safety card, and there's also an app that's similar to help clinicians guide them through giving an assessment. Can parents use that as well, or is it just for clinicians?
Well, parents are certainly welcome to access them, and the safety cards are available through the SAMHSA store, and so they can be ordered in small numbers or in bulk. Anyone can go into the Apple or the Android stores and download the Suicide Safe app and take a look. I think that for parents, now, the parent probably does not want to take on the responsibility of doing a full suicide risk assessment, and there are resources that are out there that in community gatekeeper training, and then there are some efforts to develop apps that that community members can utilize. One of the keys here, I would say, is always to be willing to ask if you're worried about someone you love, to be willing to ask whether they're thinking about suicide. And because we know there's no evidence that it will put the idea in the person's head. but it may give them permission to reveal what they've been hiding. Now, I'm not saying they will definitely reveal that, but it's very important to be willing to ask the question.
Thank you. What can we do when the person doesn't want follow-up care?
Well, of course, that is one of the most difficult situations. And I think that one thing that's important is to be talking about what the person's concerns are and seeing if there's a way that they can be addressed while still receiving some level of care. So what I mean by that is the reason that they don't want follow-up care because they are worried about being put into the hospital against their will? Or is the issue about medication side effects? Or is the issue where they don't believe that they have a problem, they don't believe that they're struggling with an illness? But I think it's very important for families to get the consultation they need, even if the individual is unwilling to get help. The National Suicide Prevention Lifeline, for example, can be used for consultative purposes. So that let's say that somebody has bipolar illness, they've attempted suicide in the past, now they seem to be deteriorating. They can certainly call the National Suicide Prevention Lifeline for some advice and guidance about how to handle this situation. Certainly, if they've been in treatment and now are out of treatment, contacting the caregiver to find out what their recommendations are given the circumstances can be important. When I was in clinical practice, would certainly get that kind of call at times, from families. And even if somebody's willing to accept care, if they leave care at some point and they might be doing well, but then they deteriorate, that can bring up the same kind of need.
Thank you for that answer. So the next question, a lot of the programs you mentioned are based in the US. Are you aware if these are being implemented internationally or if there are any other organizations doing similar work in other countries?
Yes, there is similar work that is going on in other countries. So the Zero Suicide Initiative has taken place in a number of different countries. There's work going on in England. There is work being planned in Ottawa, Canada. There is some work going on in New Zealand and likely elsewhere as well. There is an effort in Europe. This isn't strictly focused on bipolar disorder. It's called the European Alliance Against Depression, and it's been implemented in a significant number of European countries. And it includes multiple levels, including public awareness about the need for importance of treatment for depression and affective disorders, training of physicians, specialty care, and other aspects. So yeah, there is an International Association for Suicide Prevention. So two resources to learn more about. I don't know what country the questioner may be interested in particular, but numerous nations do have a national strategy for suicide prevention now. And if you Google the International Association for Suicide Prevention, or if you look on the World Health Organization website and do a search on suicide prevention, you can find additional resources that may speak to issues in particular countries.
Thank you. The next question is about stigma from clinicians. So the person asking the question their daughter was told by a psychiatrist that she could not be feeling suicidal because she was smiling at the time. And unfortunately, I've heard a lot of similar stories. So do any of these programs address attitudes towards suicide in clinicians?
Yes, that's a really important point. And so, for example, ASSIST, Applied Systematic Intervention Training for Suicide, starts exactly with that issue: attitudes about suicide and about suicidal people. There's also a tendency at times in mental health to kind of inappropriately dichotomize those who die by suicide and those who are thinking about suicide or made suicide attempts, and feeling like those who say that they're suicidal are not really serious. Another example would be the phrase suicide gesture, which is like an encouragement to say that somebody did some kind of behavior around suicide, but it wasn't really serious. In our view, it should always be taken seriously. You know, so someone could be, you know, so maybe someone may not be having thoughts about suicide that moment, but they were having them an hour ago. Still very important to know. Or a person may be thinking about suicide, but has social anxiety about talking about it. So there are all kinds of different possibilities that, you know, that exist. But it's absolutely important, it's absolutely critical that clinicians and whole systems have a compassionate, focused, and comprehensive view toward suicide prevention. In one program, we found that there can be all kinds of opportunities for education when you do this. So, for example, in one place where they built it into the electronic health record, they allowed the clinician the ability to override the system about whether someone would be in the protocol where they would get the components of the Zero Suicide Initiative, but they had to give a rationale. Two examples where one clinician said, well, person doesn't need this level of intensive treatment and because they just got out of an inpatient unit. Well, as we talked about before, post-discharge is a time of high risk. So that's clearly not a reason to not have somebody receiving this level of intensified care. I should mention that the Veterans Administration has a very similar process for identifying those at higher risk and then giving them an enhanced care package or protocol. Another example was a clinician who said, well, the person's borderline. Well, people with borderline personality have a high rate of suicide, as do people with bipolar disorder, schizophrenia, and major depression, and substance abuse. So those are some thoughts.
Thank you. It looks like this is the last question we have for today. Do any of these programs address involve the Justice Department for individuals who are being seen in court or other things related to that?
Yes, to some extent. There have been a number of discussions with justice systems and different agencies. So SAMHSA has a large youth suicide prevention effort. And we usually require as part of that the juvenile justice system be involved in the grant programs. As an example, in the state of Utah youth suicide studies showed that 63% of the youth who died by suicide over a 3-year period in the state of Utah had previous juvenile justice contact, compared to only 30% who had previous mental health contact. And so the importance of linking to juvenile justice was particularly important. There's also been a focus on justice systems, certainly on suicide among those under custody, but also for those who who may be on probation or otherwise. But I would say that more of the efforts to date have focused on youth than on adults, but both are certainly important.
Thank you. That was very informative. So it looks like that's all the questions we have for today. If you have any additional questions, you can email mleigh@ibpf.org, mleigh@ibpf.org. And then Dr. McKeon has also shared his contact information on the screen. We want to thank you, Dr. McKeon, once again for sharing your expertise with us today. We'd also like to thank our audience and would like to remind you all that all of our webinars are recorded and posted on our website. And we hope to see you at the next webinar. Thank you.
Thank you.